Hey, what's up guys? I just wanted to go over a video describing different motions of the shoulder complex, along with going over a flowchart later on of what happens and what you can do to identify specific regions that may be problematic and what you can do to troubleshoot these items. So to get into it, originally I wanted to go over to this video trying to understand the differences and how to troubleshoot what happens if there's a lack of internal rotation simply at the glenohumeral joint, or how your arm interacts with your shoulder blade. So that was the original intention, and then I quickly realized that there's a lot more than just understanding only internal rotation, because there's a lot of different levels here. There's levels at the rib cage, there's levels at the scapula, there's levels at the glenohumeral region, and then there's also levels at both the neck and the clavicle, and how they interact, not just those last two together, but how everything interacts. The easiest thing to understand is how the humerus interacts with the glenoid fossa within the scapula. Essentially, that is something where there's a ball and socket, and that's been described in so many different manners across the whole age of the internet. But essentially, there's going to be a specific region of the humerus that's covered within, or over rather, the glenoid fossa. It's not fully encapsulated here. It's a little bit left out, so it's a little bit of a shallow socket, which allows for more range of motion and more movement to occur. So that's just the simple understanding of what happens there. The next level here is, well, how does that piece play into the rest of the upper shoulder girdle? You have a clavicle here. It goes to the sternoclavicular region. It also goes to the acromioclavicular region. So when I describe this, when I'm talking with athletes, is you have a clavicle, collarbone, and it goes closer here, or more proximal, and then it goes a little more distal here. So it makes a little more sense. That clavicle needs to move. Essentially, it just doesn't stay in place, because if it does, that could be limiting later on. The clavicle needs to move forwards, backwards, it needs to rotate up, it needs to rotate down. That's the easy part to understand. It also needs to elevate and go down also. So those are the easy pieces to understand. But when it goes into the next context of, okay, well, what does the clavicle attach to? Attaches to the sternum. Well, what is a sternum? The sternum is a part of the rib cage. So as you see, we're going down different levels, it starts to get a little more complicated. Because if the sternum is at a certain position, what does that mean for the rest of the torso? Because what attaches at the sternum is the ribs. The ribs attach to the sternum here, and then we can take one more level further and say, okay, where do the ribs attach? And then they also attach at the vertebrae of the spine. So there's a lot of different things here that we kind of digress down. We went down certain levels of understanding that if the glenohumeral joint does not express full range of motion, that can be traced from glenohumeral joint, acromioclavicular joint, sternoclavicular joint, the sternum, the ribs attaching to the thoracic vertebrae, and so on and so forth. So with that, where do you even begin? Because there's so many layers to it. Well, as I continued with this thought process of how is this going to kind of make this into a digestible kind of format, I was thinking, okay, maybe I can make a flow chart. So that's what I did. So before I get into the flow chart, I just want to describe briefly what can happen at each region within the shoulder complex. So I described a few of the motions, so I'm going to go into it again. And what I'm going to do is I'm going to describe how the shoulder moves, all right, at each joint. So you can do all different types of movement at the glenohumeral joint. You could do flexion, extension, internal rotation, external rotation. You can do adduction, you could do abduction, you could do horizontal adduction going inwards, and then horizontal abduction going backwards, just at the humerus moving on the glenoid fossa. Moving on, we can go into the scapula now, right? If the scapula is on the back side of the rib cage, we can get so many different movements. We can get elevation of the scapula, we can get depression of the scapula, we can get retraction or going in like you're doing a row. You can do protraction, going forwards, like reaching for something. You can do upward rotation, kind of like waving, bring your arms up in the air. And then also downward rotation, so returning back to that normal position. The next part here, right, we talked about the humerus and then the scapula. The next thing we're going to talk about now is the clavicle. All right, I talked about a little bit about the clavicle already, but to speak about it further, we can get protraction or going forward, retraction or going backwards, posterior rotation. So it's a little bit different. If I used a marker, if you see the letters on this, posterior rotation like this, the letters are going posteriorly as it goes this way, anterior rotation going the other way, and then you get elevation and depression. So if this is my clavicle, all right, so those movements need to happen there. So the ribs interact with a couple different pieces, both the sternum and the backside, the vertebrae. So if we were looking at the backside, if this is a rib and the letters are where we're looking at how rotation happens, there is going to be motion. So they attach top vertebrae, bottom vertebrae. So they attach right here. So they attach to both of these. Some of them do. So at its essence, there's going to be some motion occurring as inhalation and exhalation occur. So that's going to be an important piece because essentially this is going to allow for internal and external rotation of the ribs as you breathe. So if I were to take a big inhale, this kind of puffing out of my chest is external rotation of the anterior portion. And then as I exhale, I'm getting internal rotation. So that's how the ribs can dynamically expand and compress. All right. So with that being said, that's a little bit of a background for how these motions can occur. So we're going to get into the flow chart now so that we can begin to understand how to troubleshoot. I don't want to necessarily say diagnose because there could be a lot of things going on. So we're going to identify how we can improve upon this lack of range of motion.
So what we have here is a shoulder mechanics flow chart. So at its essence, we start up here and then we work our way down, and then we talk about some other stuff afterwards. At its essence, again, what we're going to look at is each region has a specific criteria we're going to adhere to. We're going to look at, okay, if something has range of motion, that's good. If it doesn't, we're going to try to identify why it doesn't have that range of motion. So we're going to first start at glenohumeral joint. Can it express full range of motion, right? Can it go through all those different motions that I described earlier? If yes, cool. You don't need to do anything. If no, there's one or two things we can do. We can either check the roll, the glide, and the spin, and or check the musculature. So one of these two things, the mechanics of it or how the muscles affect the glenohumeral joint. And there's a lot of different muscles that obviously attach on those two regions. Again, the other side of it is, if no, can the scapula express full range of motion? So they are obviously connected because glenohumeral joint are connected, are one entity of two different things. And if the scapula cannot express full range of motion, right? Because if it's yes, then we're good. But if it does not express full range of motion, we're going to go to the next tier. We're going to check the musculature that connects to the scapula. There's 17 different muscles that connect to the scapula. It's a lot of them. So we're going to maybe not go through each one piecemeal, but we're going to identify specifically what is the motion that's missing. And then we're going to try to identify out of this maybe its own little flow chart of like what to do outside of that. The other side of it is if it's not able to express full range of motion, can the rib cage dynamically expand and compress? So we were talking about how the rib cage moves. Can it expand, and then can it also come down? So that's a very simple way to go about it. If it's yes, then again, that's all good. So we're just going to go back up the chain and say, okay, so we're missing something here. But if it's no, we're going to be having a little bit of a different criteria again. We're going to identify the specific musculature that controls or attaches to the rib cage. In this case, it's abdominals, a lot of the back musculature, the erector spinae, lats, all these different things attach on the rib cage, and then hopefully find something that might be lacking the control or might be having some other issues. All right, and that's its own kind of process on its own. The other side of it is not just the rib cage, but specifically, right? This is a limiting factor. This is a stopgap in where we're trying to understand what's going on. But can the first rib move independently away from the clavicle upon exhalation? So it's a lot of words, but essentially if I inhale and then I exhale, but this rib cage, specifically the first rib, does not move independently of the clavicle, well, then we have a problem. So if I'm going to use some markers here as an example, this black marker is the clavicle and this one is the first rib. As I inhale, they both go up. Makes sense. They need to inflate. And then as I exhale, if this guy does not keep on compressing, because the clavicle is not a rib, the first rib needs to compress and get rid of air and move down. If it doesn't get separated, there could be some different muscles there that are problematic. So we need to look for those. And this is where we're going to go here because, again, if the clavicle is an issue or the first rib is an issue, we're going to see, can the clavicle express full or relative motion of all the movements that we talked about, right? We're going to see here, can it do this posterior rotation? Can it do anterior rotation? Can it do retraction? Can it do protraction? Can it do elevation? Can it do depression? So all those items that we're looking at, can that occur? If yes, cool. If no, we have a couple different ways to go here. We're going to try to identify the specific musculature that attaches to the clavicle, specifically the anterior thorax muscles and or lateral neck. So what we're going to look at here is the anterior thorax. There's pec minor, pec major, and also the subclavius that sit underneath here. So if this is the clavicle, this is the first rib, it's like right here. It could get stuck. So what we're going to do is we're going to check it, all right, whatever that means for you. And then the lateral neck, a lot of different muscles there as well. And essentially that could also mean, can we move our neck within that thought process? And the other side of that, right, of the no option here is we're going to check the mechanics of the clavicle. Can it roll? Can it slide appropriately? Perhaps there was a traumatic event that occurred and it's not moving properly. So what is going on in this flowchart? If what we're trying to do is have good range of motion throughout the whole shoulder joint, well, if the clavicle is now expressing full range of motion, right? Say we did check that anterior thorax, and then it can express full range of motion. Okay, we're going to go back up a tier. Can that first rib now move independently? Okay, yes, now we're going to go back up a tier. Can that rib cage dynamically expand and compress? It might take a little bit of time, but if it can that scapula now express full range of motion? Okay, yes. And then now finally, can that glenohumeral joint express full range of motion in whatever the motion is, internal, external, flexion, extension, et cetera, et cetera. So with all that being said, if all of those things are occurring, we're back here at the top, and then we go over here. So we have full range of motion in everything. All these tiers are cleared, but we still have pain. Perhaps something is up. Something is a little bit more than just a range of motion issue, right? It's more than just mechanical. There could be some other type of insidious kind of thing going on. It could be some type of labral tear. It could be some type of capsule issue, whether it's at the clavicle, the glenohumeral joint capsule, or otherwise. So there could be some other things going on other than just these 1, 2, 3, 4, 5-ish kind of things. So hopefully this was helpful for you. This helped me out to kind of understand where my brain's at with respect to the shoulder joint. And I think that, if anything, I'm going to hopefully put more information out and hopefully help you out there as well.